As you guys know, it's a personality style, if you will, so there's no way to kind of excise it out, cut it open, and look at it. So a lot of these are theories. It talks about the dysfunctional family environment. We used to, what was it in old Freudian, the psychogenic mother and things like that? I'm not sure if that's really the case, moms, so don't worry. But the dysfunctional family, but there is something about the family is unstable. So you go back to your goodness of fit information, the old Winnicott's research. There is something about the dysfunctional families tends to be seen in folks who we call borderline. Oftentimes, and you probably do this yourselves, when you come across somebody who has a history of emotional dysregulation, we look for trauma history. Somehow we've been taught or believe that trauma leads to this, to the disintegration of the ego. The younger it is, the less likely the ego has formed. Now we're believing that the ego formulation kind of gets more finalized, not until the mid to late 20s. So trauma effects are no longer just related to childhood. Okay, so we have hereditary factors, perhaps. I don't know enough about the research to say that personality styles are hereditary, but they're certainly learned. And then we have brain chemistry. There is something about brain chemistry that, where a depression or an anxiety then becomes the fuel for a personality style. It kind of leaves just the overt behavior and becomes more of a way of engaging the world, all right? We know that, one of the things that motivates a person who has BPD, emotional dysregulation, is to avoid abandonment. They're the clingy patient, and then they become the disengaged patient. It scares them. So this is really tough because they're afraid of the connection and they're afraid of the abandonment, which why, it's one of the old psychodynamic maxims. You don't go on the borderline roller coaster. You stay flat. They go up, you're flat. They go down, you're flat. You just stay with them. You acknowledge, right, in dialectical behavioral therapy, DBT, you acknowledge where they're at, but you don't agree with it. And you certainly don't go on the railway car with them. You just don't do that, okay? So we have an unstable sense of self. So if you've ever administered a Rorschach or the MCMI or the MMPI, this will come out. It'll actually say that. Disintegrated ego or unstable sense of self. Somehow they don't know who they are. And when you're getting that with, it's one thing to say, I'm not sure if I should choose that job, or I don't know if I'm, ready to get married yet, or whatever. But when it's somebody in their 20s, 30s, 40s is saying, I don't know who I am, well, that's a little bit different. That says to us, so there's something happened to their ego. The construct of ego did not formulate, didn't coalesce. I think the challenge that I see with this crowd is if they're having difficulty, and you may have had folks with AOD say to you they can't handle a 12-step program. I just can't listen to these people whine and complain and tell their story. It's relationship. They can't handle the ups and downs of relationships. No more than they can handle. Maybe in the one-on-one with you, they're a little bit more contained. But if you've got somebody with BPD and an addiction, well, one of the things we want them to do is to get into these 12-step, or SMART programs. And that's very important for sobriety, at least in my view. They almost need to be taught how to handle it. When somebody starts to say things that upset you, get up and go get a cup of coffee. We almost have to coach them through a 12-step meeting, right? But these are the people who, and I've had them where, I just can't go to that anymore. I can't stand listening to that. These are the folks who act out. I think it's interesting, and we see this a lot. I don't know if you've ever done this, but it's interesting if you do this. When somebody cuts, and they do a little cut, and they come in. You ever ask them, why didn't you do the whole thing? Why didn't you just go? It's interesting to do that. To ask, now, of course, you have to do that if you're in a safe environment. But I think it's fascinating to ask people, well, you did that. You had the knife, you had the wrist. We had a kid recently took a rock and told people she was going to kill herself and started smashing her wrist. Well, you ain't going to die smashing your wrist with a rock. You know, that's just not going to happen. So, of course, you know, we asked her, you know, you're in pain. What's going on? Let's talk about this. So I think it's always interesting when somebody comes in with a self-injurious act as a badge of honor, you know, and wants to present it to you. You know what I did this weekend? You know, I went to the ER because I swallowed, you know, blah, blah, blah. It's interesting to go into that with them. You know, again, assuming that there's a safe environment and that, you know, you have all your precautions ready, because they're giving you information. They're giving you absolute strategic information to use. It's not like, I never just gloss it over, oh, well, thank God you didn't die. No, we can't do that. You know, I think we really have to explore that. BPD, fluctuating moods, okay, kind of like, you know, bipolar, this chronic feeling of emptiness and depression. I don't know who I am, and I feel lousy about that. There is paranoia, not psychotic paranoia, not delusions, but there is paranoia. And if you're comfortable with this, it's always fascinating to go into the content of the paranoia. All right, when they say, you know, I don't trust you, or, you know, I think you're, you know, doing this or that. Because invariably, you're in a transference experience. You're having your transference is out there for all to see. They are saying that you are like somebody else in their past. And you are ostensibly not a blank slate, but a non-judgmental slate. But they're endowing you with their history. So it's always interesting, I think, to go into the content of the paranoia. When they're doing overt behaviors, one of the things you have to figure out is, it goes back to assessing client capacity, is this catharsis, depending upon how you feel about catharsis as a construct, or is it a deficit in executive functioning? Are they just overwhelmed and they don't possess the executive skills to manage that? So again, you have to make that decision, you know, when you're interpreting this behavior. All right? Now,